Well, thank you so much. It's really great to be here. I'd rather be with you in India, and one day those opportunities will represent themselves again. But for now, it's great to be able to present this lecture to you. So in 15 minutes, I'm going to cover the topic of mitral valve disease, to clip or not to clip. These are my disclosure statements. So I think when we consider mitral valve disease, it helps to go back to the original Carpentier classification, which still is useful. And as you recall, Carpentier broke up mitral regurgitation into type 1, which is normal leaflet motion in position, type 2, excess leaflet motion, type 3A, restricted leaflet motion throughout the cardiac cycle, and type 3B, which is restricted leaflet motion in systole only. And as you can see, under that classification, we can look at primary or degenerative mitral regurgitation as types 1, 2, and 3A. And there's also secondary mitral regurgitation, which is primarily the situation where the valve is essentially normal and the problem is either abnormal left ventricle or sometimes left atrium. And you can see Carpentier type 1 is atrial functional MR or global left ventricular dilatation, which leads to a non-ischemic cardiomyopathy, and that leads to a central jet because of lack of coaptation of the leaflets, or ischemic cardiomyopathy type 3B, which leads to usually just restriction of the posterior leaflet after a posterolateral infarct. So we always think of mitral regurgitation as either primary or secondary, where there's a diseased valve, or primarily the valve essentially normal and there's a diseased cardiac chamber. Now, when we consider correcting mitral regurgitation with the MitraClip, of course, we've got to think of alternative technologies. And surgery has been the gold standard to correct mitral regurgitation for a long time. And the advantage that the surgeon has is that there are numerous techniques, both established and those that have been recently introduced, that allows the surgeon to look at the exact pathophysiologic derangement and morphology of the mitral valve and to tailor his or her adjustment to that disease or etiology of the valve. Now, when you look, though, there's really a paucity of data in the cardiac surgical literature as to how effective mitral valve repair or replacement is. In fact, there's no randomized trials. Now, in degenerative mitral regurgitation, there are multiple studies that suggest, though, that a good mitral valve repair will place the patient back on their expected age and sex anticipated survival. So these are registry data, this one of the largest from the Mayo Clinic, and you could see, again, we expect patients to do quite well after a good mitral valve repair, and we know that there are relatively few recurrences and need for repeat operations. The situation is very different after functional mitral regurgitation. Here, again, there's no randomized trials, but here, when we look at registry data comparing outcomes of patients with cardiomyopathy and secondary or functional mitral regurgitation that are either treated medically versus surgery, we don't see differences in cardiac death, overall survival, or composite endpoints. This, the most widely quoted study from many years ago from the University of Michigan, is probably the largest in 419 patients, but it really shows no differences in outcomes with surgery, which for secondary MR is primarily an undersized rigid annuloplasty ring. No differences, though, with medical therapy. And we know the recurrence rates for surgery for functional mitral regurgitation are also much higher than after a good repair for primary or degenerative mitral regurgitation. So if you look, for example, in the United States as to how mitral valve surgery for mitral regurgitation is practiced, the vast majority is for primary or degenerative mitral regurgitation. Only 4.2% of isolated mitral valve operations in this 87,000 patients from the STS registry are for functional mitral regurgitation. So the standard of care for functional MR is medical therapy because of the lack of evidence for surgery. Whereas for primary MR, surgical repair, better than replacement, is the standard of care. So now we bring in the MitraClip, and you're all very familiar with this. This does, with a transcatheter clip from a transeptal venous approach. It clips the anterior and posterior mitral leaflets together, and it creates this double orifice or bow tie repair, which was based on the original Alfieri stitch, a surgical technique developed by Ottavio Alfieri in Milan. And this was first tested in the Everest 2 randomized trial, which was really the first randomized trial in the mitral valve space. This now, about a decade ago, was 279 low-risk patients enrolled at 37 sites with severe mitral regurgitation. Now, at this time, I must say, we didn't even realize how important the distinction between degenerative and functional MR was. And so we put all these patients together. 3/4 had degenerative MR, 1/4 had functional MR. They all had to have the appropriate criteria for the MitraClip. And they were randomized 2-to-1 back then to either the MitraClip or to surgical repair or replacement, with repair being preferred. And these patients were followed through 5 years. Now, as you remember, the primary safety endpoint, a composite of major adverse cardiac events in 30 days, was much superior in the device group. Not surprisingly, the MitraClip is a much safer procedure than mitral valve surgery. However, the MitraClip was not as successful as surgery was. Success here defined as death, major stroke, mitral valve reoperation, urgent or emergent cardiovascular surgery. Those are the safety. The effectiveness being defined as freedom from death, mitral valve surgery, or reoperation for mitral valve dysfunction, or recurrent moderate or severe MR at 12 months, was only 72% in the device group, but 88% in the surgery group. And so based on this, surgery remained the standard of care. However, when we looked at multiple subgroups to see if there were any subgroups that seemed to do somewhat better or worse with the MitraClip versus surgery, the only subgroup that really came out was whether the patient had functional or degenerative MR. And if the patient had degenerative MR, clearly outcomes were better with surgery. If, on the other hand, the patient had functional mitral regurgitation, you could see the outcomes were relatively similar with surgery and MitraClip. In fact, if anything, the point estimates slightly favored the MitraClip. Now, given that surgery had never been proven to improve outcomes in functional MR, you could interpret this as showing that the MitraClip is as good as surgery, but maybe the MitraClip doesn't provide any benefit either, because surgery hasn't been known to provide any benefit in functional MR. And in addition, the functional MR subgroup was a relatively small group. So this was, again, only 27% of the patients. So you can see only about 72 patients. So this was all hypothesis generating. So after this, what became clear was that for primary MR, surgery remained the standard of care. And these are the most updated 2020 guidelines from the United States. And you can see here for primary MR, they break it down into the patient, whether the patient is asymptomatic or symptomatic, and then according to left ventricular function and hemodynamic measures, they either recommend surgery or medical therapy. But if we look at the symptomatic patients, if the patient is considered a candidate for surgery, then surgical mitral valve repair or replacement, with repair strongly preferred, is the standard of care, and that's class 1. But for patients that are prohibitive risk for surgery, then if the patient is a candidate for transcatheter therapy, then transcatheter mitral valve repair with the MitraClip is recommended with a class 2B level of evidence. And this was based on registry data that showed that for these prohibitive risk patients, at least patients that underwent MitraClip treatment seemed to feel better. But this was from non-randomized data. But still, it was enough for the FDA to give an indication for this and for the guidelines to adopt the MitraClip for this limited indication for primary MR. Now, what about for functional MR? Well, the guidelines were silent on functional mitral regurgitation after the Everest 2 trial because there wasn't a control arm of the standard of care, which was medical therapy. So here in functional MR, which is the most common type of mitral regurgitation, the disease is usually the left ventricle in about 90% of cases. So you can have either an ischemic cardiomyopathy where you have usually regional left ventricular dysfunction, and you get geometric, apical, and lateral dislocation of the papillary and posterior papillary muscle, and this tethers the posterior mitral valve leaflet, and it causes lack of coaptation. And so you get an eccentric posterior jet. Or you can have idiopathic dilated cardiomyopathy where the left ventricle is just globally dilated, and so you have both the anterior and posterior mitral valve leaflets get tethered, and you get more of a central jet. In about 10% of the cases of functional MR, the situation may be primarily angular dilatation due to usually atrial fibrillation, and that can also lead to lack of coaptation of the mitral leaflets. But again, the standard of care right now for this is to treat the underlying heart failure, which is beta blockers, ACE inhibitors, aldosterone antagonists, etc. So to see if the MitraClip could improve upon the outcomes of patients with functional mitral regurgitation due to left ventricular cardiomyopathy treated with a maximally tolerated guideline-directed medical therapy regimen, we performed the COAPT trial. And this was a 614-patient study in which, again, those with New York Heart Association class 2 to 4A symptoms, despite best medical therapy with a left ventricular ejection fraction of 20 to 50%, were randomized 1-to-1 to either just stay on the best medical therapy or to reduce the mitral regurgitation with the MitraClip. And again, the main insult here is left ventricular dysfunction. So it was really unknown whether reducing secondary mitral regurgitation could improve the prognosis of these patients. And as you know, our primary endpoint was all hospitalizations for heart failure within 24 months. And by reducing the excess volume overload of severe mitral regurgitation in these patients, we were able to markedly reduce the need for heart failure hospitalization. About a 50% reduction. The number needed to treat to prevent one heart failure hospitalization was only 3 patients. So markedly, highly statistically significant. And in addition, all-cause mortality was reduced. And we didn't know if this was going to happen or not, but we are very pleased to see that it did. And you can see, in contrast to heart failure hospitalizations, which occurred almost immediately, the reduction in heart failure hospitalizations, here it took some time for the benefits of decreased left ventricular volume overload to translate into reduced mortality. But at the end of 2 years, there was an overall absolute 17% reduction in mortality, a number needed to treat of only 6 patients to save 1 life within 2 years with the MitraClip. And if you try to compare this to other standard class 1 medical guideline-directed therapies, you can see ACE inhibitors, beta blockers, ARBs, aldosterone antagonists, Entresto, et cetera, all will save about, the numbers needed to treat to save 1 life in those with HFrEF, that is an ejection 40%, is somewhere between 20 to 50. You have to treat 20 to 50 patients to save 1 life. In contrast, in COAPT, in the patients with an ejection fraction of 20 to 40%, you needed to treat 5 patients to save 1 life. So the effect of the MitraClip was much more effective than these other class 1 therapies in reducing mortality. And in addition to this, patients felt better, they had better functional capacity, and there were almost every outcome we looked at was improved, including the need for LVADs and heart transplants. So clearly this reduced the progression of left ventricular dysfunction by reducing the excess volume overload by severe mitral regurgitation. And the MitraClip is one of the safest procedures that we do in the cath lab. We had an objective performance goal. You can see of multiple different device-related and non-device-related complications. And at the end of a year, only 3.4% of the patients treated with the MitraClip had an adverse event, mostly single leaflet device attachments, compared to an allowed objective performance goal of 12%. Now, there was one other trial, as you know, that looked at MitraClip in functional mitral regurgitation, and this was the MITRA-FR trial. And on its surface, this did not look that different than COAPT. Symptomatic patients with ejection fractions of 15 to 40%, randomized 1-to-1 to medical therapy alone versus medical therapy plus the MitraClip. Now, there were differences between this trial and COAPT, and those differences translated into MITRA-FR being an absolute negative trial over 2 years, similar rates of death and heart failure hospitalization, versus COAPT, again, being very, very positive. And there are many differences we could perhaps discuss. But perhaps the biggest difference was the types of patients and the severity of MR and left ventricular dysfunction that were enrolled. As you know, Paul Grayburn and Mill Packer came out with this concept of proportionate versus disproportionate mitral regurgitation, which basically relates the severity of MR as measured by the effective regurgitant orifice area compared to the size of the left ventricle as measured by the left ventricular end diastolic volume. And according to the Gorlin equation, you could see what would be expected if you had severe mitral regurgitation. And if you have an EROA greater than that, you can have disproportionately severe MR. If you have an EROA less than that, then it's by definition non-severe MR. So basically, disproportionately severe MR is proportionally severe MR is severe MR. Disproportionately severe MR is very severe MR, and non-severe MR is non-severe MR. Now, in the COAPT trial, we limited the size of the left ventricle that could be enrolled to a left ventricular end systolic volume of less than 7 centimeters. And we also required severe mitral regurgitation by the multiparametric United States American Society of Echocardiography criteria. So we ended up with only moderately enlarged ventricles and an EROA of around 0.41 centimeters squared, so very severe MR. In MITRA-FR, on average, they did not have an upper bound to how bad the ventricle could be. So they ended up with very dilated ventricles on average, and they allowed less criteria for how severe the MR had to be. So their EROA was only about 0.3 centimeters squared. And as a result, these are the mean values, so there's obviously a cloud of the values around each of these. But as a result, the typical patient in COAPT had very severe MR, whereas the typical patient in MITRA-FR had either a severe MR, with many of them having non-severe MR. So this was probably the biggest difference why COAPT was positive and MITRA-FR wasn't. So very severe MR will benefit greatly from the clip. Severe MR will also benefit from the clip, but non-severe MR do not benefit from the clip. So the guidelines have responded to the data from COAPT, and this is now the updated guidelines for symptomatic secondary mitral regurgitation. And again, it is a very complicated strategy, but basically they say for isolated secondary mitral regurgitation in patients that are not needing bypass surgery, they say if you have the COAPT criteria, then TMVR is now the standard of care. And that's TMVR with the MitraClip. So in my concluding slide, severe mitral regurgitation to clip or not to clip, let's come back to the Carpentier classification, and let's consider based on this who are clip candidates. So for primary mitral regurgitation, if the patients have the appropriate clinical and echocardiographic indications, that's going to be symptomatic mitral regurgitation, appropriate for MitraClip. The patients who are primarily should be considered for clip are those who had high and prohibitive surgical risk. Otherwise, surgery is the standard of care. Now, the outcomes of the MitraClip have gotten much better over the last decade with increasing operator experience. And it's very possible that for intermediate surgical risk patients, the MitraClip may be safer and now as effective, or at least given the difference in the safety between the MitraClip and surgery, may be considered reasonable. And there's at least 2 randomized trials that are ongoing now, one in Europe and one in the United States, of MitraClip versus surgery in intermediate risk patients with primary or degenerative mitral regurgitation. For secondary mitral regurgitation, basically, MitraClip candidates are those who meet COAPT criteria. That is, patients who are symptomatic, on maximally tolerated guideline-directed medical therapy, who have 3 to 4 plus mitral regurgitation by, again, the multiparametric echocardiographic criteria, a left ventricular ejection fraction of 20 to 50%, ventricles not too large. I mean, an LVESD of 7 centimeters, that's still large, but at least it's not a giant blown out ventricle. And perhaps those without severe pulmonary hypertension or severe RV failure who were also excluded. But the question really remains, well, what about other patients with functional MR? What about those who are asymptomatic, not on maximally tolerated guideline directed medical therapy? What about those with 2+ mitral regurgitation with a non-dilated left ventricle, or 3+ or 4+ MR with a very dilated LV? What about the stage D or shock patients, higher or lower left ventricular ejection fractions, or atrial secondary mitral regurgitation? Those patients have not yet been studied, at least not in randomized controlled trials. I suspect that many of those with secondary MR and those classifications would benefit by the MitraClip, but we need to do more studies before we can routinely recommend that as Class 1 guideline-directed therapy. Thank you very much.
Thank you very much for such a wonderful lecture on mitral valve disease and regurgitation, to tip or not to tip. This has actually put things in the right perspective, and probably this is something, the structural revolution is the revolution of the future. And this is something which all of us want to learn and apply to our patients. Today we had Dr. Horsey talking about the structural revolution as well. We also had Dr. Alan Lumpton who was talking about robotic intervention and those who have professional operation. So all of them clearly were non-coronary topics, the APVIC for peripheral and structural heart disease. I do remember you releasing our book on handbook on structural and peripheral vascular interventions in the PCP years back, and it turned out to be a bestseller in India and in Europe for a long time. Dr. Gregg Stone, if there are any questions from the panel, I would take those questions first and give it to our co-chairs. If there are none, then we will be starting with the Q&A from the panel itself. Dr. Manjunath?
Dr. Gregg Stone, is there any difference between the ischemic and non-ischemic functional MR in terms of prognosis? And how often you use multiple clips, say, and what would be your, when do you say it is successful?
So in terms of ischemic versus non-ischemic mitral regurgitation, there are some studies in the literature to suggest that the ischemic patients, once you correct for ejection fraction, have a worse outcome because they have associated coronary disease and they tend to have more comorbidities, they tend to be somewhat older, et cetera. In the COAP trial, there was no overall difference in prognosis according to that breakdown, and there was no difference in the effect of the MitraClip on the improvement in those patients. So we were very interested to see that, and the FDA was very concerned about that as well. As long as you can get a good transcatheter mitral valve repair, you will improve both symptomatic outcomes and longevity in patients with both ischemic and non-ischemic cardiomyopathy. And your second question was, how did you define success, I believe, with the MitraClip? And we defined it as less than or equal to 2+ mitral regurgitation by echocardiographic criteria. And, you know, it can be difficult to assess how severe mitral regurgitation is after the MitraClip, but still core labs kind of know what they're looking at, with, of course, no procedural MACE. And it turns out that, you know, we had procedural success in about 95 to 96% of the patients in this trial with that definition, and about 80% of the patients achieved 1+ or less mitral regurgitation acutely from the MitraClip. So the outcomes have improved much more since Everest 2 in terms of procedural outcomes. Everest 2, the success rates were only about 78%. Here we're up to 95%. And the big difference is, again, experience with the operators and much better imaging and imaging guidance compared to a decade ago.
Regarding number of
you had some question?
Number of clips, regarding number of clips you require in the trial?
Yeah, the average was about 1.7, ranging from 1 to 4. One patient even had 4 clips. About a handful of patients had 3 clips, but the median was around 1.7. So the average was around 2 clips per patient.
Okay, thank you.
Yeah.
Dhoni, you had some questions?
Yes. All right. Okay. I would like to address to Dr. Stone. Greeting from Jakarta, Indonesia. So our experience in MitraClip is very limited. My experience, less than 30 cases. But I want to ask regarding the right ventricle function, because especially for long functional mitral regurgitation, in my experience, if the patient coming with very bad right ventricle function, so the long-term outcome is also not very good. So what do you think about it?
Yeah, I think that's very important. The right ventricle often determines the prognosis in these patients. In COAPT, we excluded patients with moderate or severe right ventricular dysfunction. We had many patients with mild right ventricular dysfunction, and actually some did get in with moderate right ventricular dysfunction. We're doing all those analyses now, and in addition to TAPSE and right ventricular fractional area shortening, the usual ways to look at RV function, we've also now done a detailed analysis of right ventricular global longitudinal strain, and so we'll be reporting those data later according to outcomes in COAPT by RV function.
This is Dr. Manjunath. So I just wanted to know what is the impact of mitral annular calcification with respect to outcome of clipping, if there is an associated mitral annular calcification?
Yeah, well, that certainly can be one of the limitations of the mitral clip, and we excluded, and almost all studies have excluded patients with severe mitral annular calcification.
Dr. Stone, like in aortic valve replacement, we have a number of devices coming in, and there are many choices. In terms of mitral clipping, do we have only one device, or we have many in shelf and are in progress, and they would be coming? Because in India, the most prohibitive factor is the cost, and the insurances do not cover, the government doesn't cover that. So,
well, there's no doubt once we get multiple devices of the same or competitive devices, that will bring the cost down. So there's at least 3 or 4 other edge-to-edge techniques that have been introduced. The one that's, of course, very far along is the Edwards-Pascal device, which kind of has wider paddles and is being tested right now compared to the mitral clip in 2 randomized trials, one in functional MR, the other in degenerative mitral regurgitation. Those are non-inferiority trials, and I think most people expect that that will meet non-inferiority, and if that's the case, that will give us an option there. And then, of course, there's numerous other types of devices, including transcatheter annuloplasty devices, either direct or indirect, LV reshaping devices, and, of course, transcatheter mitral valve replacement. And where all of these fit into the treatment of patients, particularly with secondary MR, compared to the mitral clip, is going to take us a decade to figure out. And it's going to be very interesting to see how that factors out. In addition, of course, transcatheter mitral valve replacement, everyone's very excited about how that will compare to surgical transcatheter mitral valve repair or replacement is also going to be interesting to follow. A lot of that's going to depend on the type of anticoagulation and the duration of anticoagulation that's required, and how safely we can do it and how broad a patient population without getting left ventricular outflow tract obstruction, hemolysis, or other complications of the procedure.
do you see any future in these clips or any other device for treating rheumatic mitral regurgitation? Because that's another subset which you see in Southeast Asia and India. Any program?
Rheumatic, yeah.
Yes.
So for rheumatic disease, again, similar to surgery, I think it's on the transcatheter front will primarily be transcatheter mitral valve replacement, which I think, a substantial number of those patients might be eligible for. Occasionally, a transcatheter neocord may be an appropriate treatment, but usually I think, the pathophysiology, the pathology of the valve is going to be too far advanced to do much on the repair front.
Thank you very much, Dr. Gregg Stone, and thank you for sparing your time. I know it's time also for EuroPCR, and we have many more questions, but we have another session coming in after this. And I hope you continue your association like previous years with Asia-Pacific Vascular Society. And we definitely want to have stronger ties with Asia-Pacific Vascular Society with CRF and TCT. This year, we have registrations for about 8,000 people already. And hopefully by the end of the conference, we'll have more than 10,000 registrations. Thank you once again, and greetings from India and all of Southeast Asia.
Thank you so much. It's our pleasure and honor to collaborate with you. So I do hope that our groups get closer together. Thank you very much. This has been a real joy.
Stay safe, stay home.
Thank you, everybody.
Thank you. Okay, so this was a very interesting session, although we went a little over the time.